Hello and welcome to the Genetics Podcast. I'm your host, Patrick Short. My background is in population genomics and studying the genetic causes of rare disease. I did my PhD at the Sanger Institute in the University of Cambridge and have been in biotech since 2018 when I started Sonogenetics. Sonogenetics helps academic and industry researchers to run large-scale genetic testing programs that speed up their clinical trials, generate data sets for the next big breakthrough, and give participants the best possible experience taking part in research. Each episode of the Genetics Podcast, we bring you insights from the leading minds in genetics and precision medicine, including household names and Nobel Prize winners, as well as early career scientists and biotechs working on the next big breakthrough. Whether you are a scientist, entrepreneur, executive, patient advocate, or simply someone curious about how genetics shapes our world, you're in the right place. Thank you for listening, and let's get started. Welcome back, everyone, to the Genetics Podcast. I'm very excited to be here today with Dr. Zornitza Stark, who is a clinical geneticist and a leader in genomic medicine. She is the co-lead of translational genomics research at Murdoch Children's Research Institute in Australia, professor at the University of Melbourne, and a consultant clinical geneticist at Victorian Clinical Genetics Services. And I got in touch recently with Zornitza after seeing a really interesting paper come out with her and her collaborators on a new program called BabyScreen Plus. I'll say new. You've probably been working on it for many, many years, but it's new to most of us who've read the paper or may read the paper after this. And you've also done a lot of work in rapid newborn genome screening, and it is I think the age of the newborn screening right now. It's got a huge amount of potential, and it's an area that I'm particularly interested. So I wanted to talk today, explore the paper, and a little bit more about your career and where you see the field going. So thank you for joining us.
Thank you very much for the kind invitation.
Let's start with the paper for people who haven't read it. What did you study? What did you find? And what surprised you about it? Because you probably had something in mind when you started it, but I would love to just hear what the big takeaways from you from the first tranche of the program have been.
Yes, genomic newborn screening is a highly topical area at the moment, and there are multiple studies happening concurrently around the world in a diversity of healthcare systems trying to explore this idea. The idea has been around probably for around 20 years, and there's been a lot of talk about the potential of sequencing the genomes of all newborns at birth. But up until about 5 years ago or so, I would say we didn't really have the technical capability to embark on something like this. So over the past few years, quite a few research teams around the world have felt the time is ripe to actually try and test it out in practice. Our study, the BabyScreen Plus study, which we run here in Victoria, Australia, is relatively small. So it was a prospective cohort of 1,000 newborns. We performed whole genome sequencing using the existing newborn screening cards. So that, I guess, really makes full use of the existing pathways for sample collection that already are in place in the healthcare system, so reduces the burden on participating families and babies. So we used the existing samples, performed whole genome sequencing, and looked for around just over 600 conditions associated with severe early onset but treatable diseases in children. We had 16 screen positive results, which were all confirmed on secondary testing. And the results had quite a range of implications. Some of them, such as G6PD deficiency, which has been the commonest result, is relatively low impact, both for the healthcare system and for parents. We just provide advice on foods and medications to avoid, and armed with that information, hopefully parents should be able to avoid triggering a hemolytic crisis in their newborn inadvertently. And at the other end of the spectrum, we detected a baby with a very severe immunodeficiency who became unwell within weeks of us disclosing the results. But we were able to be ahead of the game. So the baby was already being actively monitored, was started on treatment very promptly, and then had a curative bone marrow transplant within a matter of months. So that was potentially a life-saving result.
That's pretty amazing. And how do you think about extending it from there? Were there questions about health economics, or is this really I mean, technically interesting as well that you can get enough data from the heel prick, right? That there are a whole host of questions that you can answer with a 1,000 person pilot like this. Where did you start and where are you taking it from here?
Yeah, so last year, three other studies published initial results. So the total now, and that's been published very recently, is 10,000. Um, and what we have learned from this first tranche of results is, I guess, several important lessons, mostly to do with the feasibility. Feasibility of extracting DNA from newborn screening cards has definitely been one big question, and I think that has now been answered. The other key aspect of feasibility here is to do with automation. Obviously, if we're going to be doing this at scale here for the population of the state of Victoria, we would be looking at doing around 80,000 babies a year, whereas we only did 1,000 over the course of 18 months. So that would be a huge step up in terms of scalability, and obviously automation is going to be very important, particularly at the step of data analysis and reporting. So we tried our hands a little bit with automation. It's a difficult balance because we want to avoid both false positives and false negatives. But we also have to think about resource use and workforce scalability. So we learned a lot of lessons in terms of what the appropriate settings would be. In our study, we still reviewed about 50% of the results manually, which is too high if we're thinking about a much larger scale. But by the end of it, we could see several adjustments that we could make that would bring that down more in the range of 10 to 20% of results needing a review by a skilled laboratory scientist. I guess we are also exploring the use of AI, particularly in terms of collecting information about variant pathogenicity. So in future iterations of this, we will be seeing more automation and more use of AI to try and get to the right scale. So those are the questions that we feel we got a good grip on the answers at the moment, but and I guess we also got an impression of what the likely screen positive rate is going to be and what the distribution is likely to be in terms of the pediatric specialties downstream of this test that will be affected. What we don't have any information on at the moment is any long-term outcome data. And you mentioned cost effectiveness. Obviously, that's a health economic evaluation of genomic newborn screening is going to be a very important step, particularly as governments and policymakers start considering where is this headed over the next 5 to 10 years, and should they be starting to plan integration into standard newborn screening.
So in terms of what you found from this about 1,000 families, you mentioned and the paper mentioned you had 16 infants, only one of whom would have been identified from standard biochemical newborn screening, right? So of the additional 15, you spoke about the immunodeficiency case that I assume is one of those that wouldn't have been detected. What the other 14, what can you talk a little bit about what you found and also how this generalize or doesn't generalize to Guardian or some of the other programs that have been found? Is there a picture emerging of you sequence 1,000 families or 1,000 healthy newborns, and we would expect to find one something like this and two something like that? I know that I'm generalizing a little bit, but it'd be good to help people wrap their heads around what we're talking about here.
It's a really good question. Actually, we've just gotten together with Guardian Early Check and Baby Detect, which are the other 3 studies that published last year. And we've just finished writing a piece that kind of combines our experience. And it was very interesting sitting together across the time zones and comparing notes Obviously, we are in different healthcare systems. And the other interesting thing is about the concurrent nature of these studies is that different studies have taken slightly different approaches to some of the major implementation questions. So we're kind of generating evidence simultaneously, and we're able to, at the end of it, sit and say, well, this worked quite well in these particular ways, and this didn't work so well, for example. In terms of the other conditions that were detected, there was a range of metabolic and endocrine conditions, which is unsurprising because they're the ones that have generally have interventions. The one thing that genomic newborn screening detects, and we need to be prepared for, are conditions that are inherited. So particularly when we screen for cancer predisposition, or if we decide to screen for cardiac conditions and a number of other conditions that are inherited in an autosomal dominant manner, chances are they will be inherited from a parent, and that can come obviously as quite a surprise. Obviously, it's a huge shock when we return a result for a baby, but they have also, for a number of the families, been flow-on effects to multiple family members, and that needs to be very carefully considered, I guess, from a number of perspectives. Obviously, we're returning these results in the first few weeks of life when, especially brand new parents, if it's your first baby, their hands are really full and trying to get their heads around essentials such as sleeping and feeding, and we are returning fairly unexpected results. Obviously, people can remember that they consented to this, but most new parents are completely caught up, completely understandably, with having a new baby and managing that. So returning that initial result for the baby is tricky, and the appropriate supports need to be in place. But on a number of occasions, we've returned results for dominant conditions, which have had much wider implications for the family. So it's not just, so again, emphasizing the need for really good psychosocial support that's also able to address the needs, individual needs of parents. And also that preparedness to link up not just with downstream pediatric services, which is standard practice for standard newborn screening, but also the need to develop good connections with adult services who will look after the adult members of the family. And those kinds of broad areas in terms of result groups have been reflected in the other studies. Some of the other studies have made slightly different choices. I mean, what's most striking about this field at the moment is the very wide discrepancy in the number and types of conditions that are being screened. I mentioned our gene list was just over 600. It's one of the largest ones around. They generally range from around just over 100, or many sit at around 300 to 400. And when you compare the criteria that we've all used, they're roughly the same, or they have the same spirit. And we all want to look for severe early onset treatable conditions. And we have all gone about making these lists of genes using multidisciplinary committees, and we have all put a lot of thought into it. But when you look at the final product, it's widely different. So just thinking about the 4 studies that we've just finished comparing the results of, when we looked at our gene lists, only 80 of the genes were in common between the 4 studies. So that actually really hampers the ability to then compare results. So the overlap is not great. Obviously, we've all realized this, and we all think we need to do something about this and harmonize our efforts. So there is work underway internationally to try and think, in particular, how the Wilson and Jungner criteria, which kind of underpin most public health programs, how should what did they look like in the genomics era, or for this particular publication, or for this particular application, or and also how to make them operational. Because in particular, newborn screening committees are very much used to considering condition by condition propositions. And if we are now going to start thinking beyond moving a research study, what does the actual process look like? Because if we stick with condition by condition, there are basically not enough hours in the day. It would take hundreds of years to consider 600 gene disease pairs. So all of that, we need to find new ways of addressing these challenges. It is interesting that a couple of the studies then offered other types of conditions as an optional offer to parents. In addition to actually trying this out, there's also been a lot of research to try and understand what the prospective parents want from this, what does the public want, and what do health professionals think. And we've tried to ascertain these views in lots of different ways, including focus groups, discrete choice experiments. Here in Australia, we recently had a citizens jury, which was a very interesting experience. People have conducted public dialogues. But regardless of how you try and ascertain these views, the views of prospective parents and the public are generally fairly consistent in that, yes, they agree severe early onset treatable conditions should be included, but about a third of people would be interested in a much wider range of results. And that includes conditions such as neurodevelopmental disorders that don't necessarily have a treatment that is curative at the moment. So it was interesting. A couple of the studies offered optional add-ons of about 100 conditions, or Guardian offered around another group of conditions that were neurodevelopmental disorders. And this was optional, but the uptake was high, I think approaching around 90%. And similarly, Early Check, which is another US study, offered another optional group of conditions, and again, with relatively high uptake of about 80% from parents. So we know parents want, or a group of parents want more information. Yes. On the other hand, every time you ascertain the views of health professionals about this, the views are much more conservative and concerned that this is moving way too fast and we should be offering way less, and certainly not anything that doesn't have immediate implications. So it's going to be a difficult balancing act in the design of future large-scale studies, and certainly when it comes to making policy decisions.
How did you land on the list of 600 genes that you included? I think 605. What are the big categories? So you have this core set that sounds like everybody agrees we can interpret it. There's a clear treatment pathway everywhere. Let's do it. But what are the other rings of the Venn diagram, and how did you think about those?
Yeah, so we thought about, so we offer the clinically accredited test through our laboratory. So one thing that was really important to us was analytical validity. So being able to reliably pick up the main variant types that cause a particular condition. So something like hemophilia A, which is caused by variants in factor VIII. That's difficult because one of the common variant types is an inversion that we know we're unlikely to be able to pick up. So something like that we would have considered as an exclusion criteria. The other thing that we placed a fair amount of weight on is clinical validity. So is the gene disease relationship really well established? So generally, the cutoff that we use is there having been at least 3 families previously reported in the literature, and preferably, obviously, more. And so that gives us a degree of confidence in terms of being able to interpret the results. Early onset, by that, we set the cutoff at 5 years. So we were interested in conditions that predominantly present in the first 5 years of life. And cause severe disability or mortality. Obviously, saying something is severe, that's very much in the eye of the beholder, so that accounts for some of the variability. And finally, that there's an effective treatment available that alters the natural history of the condition, and that the treatment's available to us locally. And variations in treatment availability, I think, also account for some of the differences with other studies. But we didn't start from scratch. I think some people did still start from scratch. But we felt at this point in time, we have the benefit of several other smaller pilot studies that had happened previously, both worldwide, and we had some attempts in the past in terms of trying to think about this. So what we did was actually collected the existing gene lists from other studies and tried to reassess all the genes that they had previously considered. And there's also a compendium of treatable conditions that is online. So that was other main source of information. But we systematically, as a committee, considered, I don't know, probably more like 800 genes, and decided a fair number of those, and kept 605. Because of the relatively small size of the study, we were not too worried about downstream healthcare system capacity. We knew we were not going to flood the system with results. So downstream healthcare system capacity was less of a consideration, whereas I know it has been a consideration for some of the much larger studies.
I understand, diagnosed 20 relatives through Cascade testing. I'd love to hear a little bit more about that, because you really do have, like, there's quite a moment here for some of these families, right, where you find something that has implications for the child, but then also potentially for other family members. Did you anticipate the scale that would happen, or how did you think about what Cascade testing would look like in this kind of program?
I'm not sure we fully anticipated the amount of Cascade testing that we did. A lot of it relates to G6PD deficiency, and that's a relatively low impact result. And it's nice being able to provide that information to multiple family members. A few of the results related to dominant conditions, and that was a lot harder in terms of result disclosure and follow-on testing, which generally had higher impact. But in some ways, it can sometimes help parents adjust to the diagnosis in their baby. I think when you have a newborn and we land a diagnosis like this, obviously most parents start asking questions like, what does my baby's life look like? Are they going to be able to do X, Y, and Z? And sometimes when the condition has been inherited and they have themselves have been healthy, that does provide, and there's additional family members, that does provide them with some reassurance that perhaps the condition, it's not going to be the worst case scenario, and the condition can be managed and can have a good outcome. And that we've just provided the opportunity for proactive monitoring and potentially intervention if needed.
Yeah, so where my mind goes with that would be some of the cardiac conditions. Like I think you identified a Marfan syndrome individual, for example. Is that the most common, the one that you think of?
Yeah, so I think if people include cardiac conditions, those are relatively common. We only included a small subset of them, where we felt there was going to be an intervention in the first 5 years of life. We actually put aside the vast majority of them because they're generally actionable later in life. But I know many other studies have included a much wider range of cardiac conditions than that, including some of the arrhythmias, and those are relatively common findings. It has been interesting for me as a rare disease clinical geneticist sitting at a large tertiary children's hospital. Obviously, I'm very biased, and the rest of my career has been spent looking after families who've been affected by rare disease at the very severe end of the spectrum. But that realization that there are many people out in the community who have variants in these genes that are clearly pathogenic, And if you sit with them, the family history is actually there. Yeah, the realization for me personally, that's been quite an interesting learning experience.
I think that once all of the programs that you and others are running, and once they start to get to scale, we're going to find some real surprises in terms of prevalence, or both prevalence but also penetrance of some of
Yeah,
these, right?
correct.
Yeah.
Yes. Yeah.
Do you have any early sense from looking at the data across programs of whether they're like what might we be missing in terms of the penetrance of what things we don't know that we don't know about rare disease?
I think that's really hard to answer at the moment for two reasons. A, the size of the studies is still not large enough to be able to answer these questions. And secondly, we haven't actually got the long-term follow-up data on the babies, let
Yes.
alone additional family members. So what this is going to need is at least another 5 to 10 years of very large scale research and meta-analysis before we can even start answering some of these
Yeah.
questions.
I guess I was thinking about it in a that would be really powerful data. I was also thinking about it almost as just a simpler way of if you took a cross section of all 10,000 newborns today, and then you did the same in the UK Biobank, where the average age
Yes,
is
that's it.
significantly older. What drops out by the time you get to the UK Biobank and
Yes.
what doesn't, right?
And I think people have been playing with the UK Biobank and turning up all sorts of interesting variants in people who appear to be
Yes.
grown up. Yeah.
Yeah, and I guess the opposite as well, right? I'm interested in which ones are selected out of the somewhat
Yeah.
biased UK biobank population. Do you have a
Yeah.
sense of how, I guess it's really just going to depend on the gene, right? There's a power calculation to be done somewhere in there. Where do you want to take it from here? Do you plan to expand the program? Is that still up in the air? How are you thinking about it?
Um, Obviously, we had a much more limited amount of funding. What we're planning to do with our cohort, who are now approaching 2 to 3 years of age, is do a second offer. I talked a little bit earlier about the fairly consistent desire from parents to obtain more information. And I think since we have bothered to conduct the research into what people want, I think we should explore that further. So we are going to get back in touch with the parents and offer additional screening, particularly for conditions with onset slightly later in childhood, or
Mm.
actionability slightly later in childhood. And the one that stands out is familial hypercholesterolemia. We probably spent 5 or 6 hours discussing as a group about whether this should be included at the newborn stage.
Yeah.
Obviously, it's fairly common. It affects 1 in 250 people. Going against, and the intervention is very well established in terms of dietary modification and medications to bring cholesterol down. And we know that's very effective. The medical intervention typically is recommended to start between the ages of 8 to 10. So it didn't make it on our list primarily for that reason. But I think we all felt to some degree that it's a missed opportunity. So that will definitely now be offered to this cohort. And we will also offer screening for neurodevelopmental conditions, because yes, we have consistently heard from parents that this is something that they would like to know about to be able to be prepared and I guess to benefit from early intervention. But those offers will be optional, and I'm interested to see how many parents take up these offers and what their choices are. So that will also explore the concept of this being a lifelong resource. We talk about the very high cost of whole genome sequencing, and people worry about, should we really be doing this, or should we be doing a much cheaper version using a next generation sequencing panel with the data then just being used as a one-off. So it will be interesting to try and demonstrate in practice this concept of reusing the data over an individual's lifetime to obtain further information when it's relevant at different time points. So that's what we're going to do with the limited
Great.
amount of money that we've got left. What I would dearly love to see here in Australia is a much larger scale study. I mentioned at the beginning, this was just based in the state of Victoria, and we would dearly love to see a big national study that would give us the scale and the pace that we really need to be testing this out at in our healthcare system. And the other thing that stood out when we looked at the demographics of our participants was that, as is usual with these things, there was an overrepresentation of highly educated parents and a disproportionately larger number of parents who spoke English as the main language at home. Obviously, Australia is very multicultural, as are many other countries, and we do need to find purposeful ways to address these imbalances and to ensure that there's equitable outcomes from an intervention like this, particularly if we're thinking about rolling it out at scale in the healthcare system in the future.
You have actually taken programs to national scale in Australia before. I wanted to talk about your work in critically ill infants. So still in newborns, but very other end of the spectrum. Maybe you can talk about what you learned there. So it's much rarer, it's much smaller, but the impact is very concentrated. And you've probably set Australian records of sequencing speed and all sorts of other fun things. So I'd like to hear about that.
Actually, the BabyScreen study has been a natural progression from a number of studies for me. I became involved with translational genomics back in 2014 when with the launch of something called Melbourne Genomics here. And at that point, the very first study that we did just tried to answer the question, what if we use this as a first tier test in infants with suspected rare conditions. So at that point, it was very much a test of last resort because it was essentially not available in our healthcare system. We were sending, anytime we wanted to do an exome, we certainly were not doing any genomes, but even when we wanted to do an exome, we were begging around the world and sending the samples out to friends in Japan or Canada to try and get answers for families who'd been in the system for 10 years or whatever. So the first question that we asked is, what if we use this as a first tier test? What if you skip all the single gene tests or the small panels that you did, and you just did this as a first tier test? We had very, very little money at the time, so the cohort was only 80 babies, and we couldn't even afford trios, so we did singletons on everyone, which was hard work. But the results were quite striking, and the exome test was able to make 5 times more diagnoses than traditional investigative pathways at the time, which is a huge leap. And we also did a fairly extensive health economic evaluation. Health economic evaluations have been very important for us because they have been something that our government wants, and it's been the main way to convince them that this is worth doing. So we were also able to show that this was actually cost effective, even though the cost of the test itself was high. You're basically able to forego a very large number of other investigations. And although those investigations individually are cheaper, they add up very quickly in the context of a sick baby. So that was interesting. The overall statistics from that were interesting, but as is often the way, I guess some of the individual stories influenced both me and everyone else who was looking at the data. So we were able to identify one treatable condition, which was a thiamine metabolism disorder. Unfortunately, it had taken us 6 to 9 months to get to a result because that was the speed with which we were doing things at the time. So this is a progressive neurological condition. It is very treatable. The treatment is a thiamine supplement, which costs like $1 a day. It's trivial. And although we were able to start treatment as soon as we got the diagnosis, the baby had already suffered significant neurological damage and was going to be significantly disabled. So we were probably able to avert death, which I guess at that point, as a clinical geneticist, I was not really expecting to be making any life-saving diagnoses in my career. So that was quite striking. But the other thing, I guess we've all felt a huge amount of regret that we had not been able to do that.
It is. It sounds very bittersweet. That what might you have been able to do with a different set of technology? Yeah.
So that's what provided motivation kind of in the next small amount of money that we got was to try rapid testing. And that was just in a cohort of 40 babies, again, based here in Victoria with money from the Melbourne Genomics Health Alliance. So we were able to cut down the turnaround time to 3 weeks, which was amazing, but still didn't feel fast enough. And there was another baby with a riboflavin transporter deficiency who had ended up in ICU with a tracheostomy and really and requiring 24-hour ventilation. She turned out to have this other completely reversible condition that, again, the treatment costs $1 a day. She definitely made a huge impact on anyone in the hospital that heard about her. So we started the treatment. She was able to come off the ventilator and eventually go home. Again, she ended up with residual disability. So at that point, we felt very highly motivated to do this even faster. And Australian Genomics arrived on the scene. So that was a national level initiative. So that provided us with the research infrastructure to run national studies. And we managed to get a lot more money at that point because we'd proven that what we were doing was worthwhile. So we ran the acute care genomic study for about 5 years. So that included all our states and territories and all our children's hospitals around Australia. With that, we were able to cut down the turnaround time to less than 3 calendar days, which is pretty impressive. And there's only a handful of laboratories around the world even now that are even capable of doing that. So that's fully accredited testing. So that was a cohort of 450 babies and children. The first half of the study was done still on exomes, and that was published in JAMA. And the second half, we transitioned finally to genomes because finally we could afford them. And we also included some interesting multi-omics, in particular RNA sequencing for the unsolved babies, and we've also been playing with rapid proteomics to try and get some of the variants of uncertain significance over the line. So
what are you learning there? Have you found anything interesting from that so far?
Yeah, no, it's been great. It has really been fascinating. We've had a lot of investment. Well, when I say a lot, we've had reasonable investment in functional genomics capacity in Australia through a number of very large grants. So we're starting to see the results of that through our diagnostic laboratory, and some of it's really fascinating and getting plenty of variants over the line. Cool. And plenty of the variants have turned out to do completely weird things that I wasn't expecting. So it's been, it has been a very interesting learning experience. The question for us is how to transition any of that into standard diagnostic care.
Yeah, it's very difficult to scale. I was going to ask a question about that because you have done a lot of work on the national and international scale curation and data sharing, and we have more of these functional methods, massively parallel reporter assays and MAVES and things like RNA and one-off proteomics. And then you have the whole other end of the literature review, case reports. Like how do you think about building a Bayesian system that takes all this different information in and tells the healthcare system what they should or shouldn't pay for at the end of the day? It's quite a daunting task in a way, but it's kind of interesting.
Yes. There were lots of parts to your question. I also run Panel Up Australia, which is a platform that provides assessment for the evidence-based assessment of the validity of gene disease associations, and also maintains a number of virtual panels. The goal of the platform is to facilitate high-quality interpretation of genomic tests here in Australia, although it is obviously completely open, and it's accessed, I think, a ridiculous number of times. I think it's now up to 1 million times a month from over 50 countries.
Wow. That's pretty
So
cool.
yeah, we got the software for free from Genomics England, for which we are eternally grateful. But the content we create completely ourselves. So it allowed us to house a lot of work that we had previously done in Excel spreadsheets into this open platform. And we have become seriously addicted to the exercise. And most recently, we've been playing with an AI mining tool, literature mining tool. So that's has very much increased our capacity to review a much wider range of literature, and has also kept us very busy. But, and you know, we have national platforms that collate information from Australian laboratories on variants that they have assessed, so that's our sharing platform. But you know, these efforts are currently fairly disconnected. We don't have coherent national genomics infrastructure, and you mentioned and I mentioned the fact that we're generating a lot of functional data now. There's not really a way of collating and recording that. So one thing that I would very much like to see here in Australia is substantial investment in national genomics infrastructure, because otherwise a lot of this information is actually just remains locked up in silos. It is not integrated, and it is not at our fingertips when we need it most, which is when we interpret the next test.
It's really great that Genomics England was able to provide the infrastructure to do that. And it had me wondering about back-end data sharing. If you can get every country, because there's going to be country specifics, right? What your health system should and shouldn't support. But there's core information that's being collected in each place. How do you think about federating or pooling that data in some way?
I have been involved with the Global Alliance for Genomics and Health for about 10 years, and we would all love to see a lot more data sharing and data federation, but it has proven a lot harder to execute in practice for us nationally, because we are a federated country. So we're made up of states and territories, and there are some questions about jurisdictional ownership of data that we have not been able to resolve on a country level. Then let alone, you know, that those problems are magnified when we think about resolving that on international level. But we really need to do that, because otherwise we're not, you know, we're spending millions and billions generating this data, and unless we have the right infrastructure and unless we enable data sharing, we are actually not making the most out of the potential of the data, and we're in fact wasting most of the potential of it.
It seems like there's an incentive issue at the core somewhere, right? That you don't get nearly as much credit as you should for contributing.
This needs to be policy driven, so that does need to be the policy directive to do it, and it does need to be backed up by fairly serious money. So this kind of infrastructure is complex, and I think has had to be invented. It's not something that you can currently get off the shelf. It does take quite a lot of effort to conceive and build. So it need that investment. And yes, we've been able to piggyback sometimes off other people's efforts and kindness. But if we're going to talk about having serious national infrastructure, it's going to take quite serious investment as well as political will for us to be able to do it. And yeah, that's probably we've done really well in Australia over the past 10 years. with the much more limited amount of investment that we've had. But if I had to name my biggest regret, it would be the absence of national infrastructure.
What are you focused on this year? Is there any prospect of building and catalyzing some national infrastructure? And if not, what are the couple things you're most excited about?
We are at a period of transition in Australia at the moment. Up until now, the state-based and national efforts have been fueled by research money. Both Melbourne Genomics and Australian Genomics came to an end in 2025, so that has been difficult. We have seen, on the other hand, the establishment of Genomics Australia, which is a new entity which sits within government. So that change in funding and the purpose and makeup of this body will now be interesting to watch, because it does sit very much within government, and I hope we'll be able to influence policy. I guess the other thing to emphasize here is that all our efforts in the past 10 years have been, we like to describe them as bottom-up. What that means is we've had to organize ourselves on the ground if we wanted to get any genomics happening in the country, and try and get small bits of money from here and then put it together to try and do something meaningful and large scale. I think that gets you only so far, and we've done very well. But what has been missing is that sort of top-down vision and policy setting and top-down investment. So I hope with the transition, or with the establishment of this new body within government, we will see some of that policy direction. So we'll wait and see.
Yeah, I hope so too. It sounds, has it got good funding? That's the key question. Depends who you ask.
Not at the moment. So the budget is very modest. But I think one of the first tasks will be to identify what are our priorities, and then help to direct future funding. So we all have our wish lists, but we have to sit back and wait for all of that to play out.
Before we close out here, is there anything that you want to leave people with? And also, it's always a good opportunity if you're hiring or have anything that you want people to show up to if you're fundraising for something.
This has been such an exciting area to work in the last 10 years. It's not really what I imagined when I went into clinical genetics, and it's still, I still feel excited every day when I wake up and go to work. I think there's a lot still for us to be doing, particularly now as we consider how this may be scaled up to population levels. So I think over the next 5 to 10 years, I very much hope we will be working on large-scale population genomics here in Australia, and certainly there's a lot of efforts already underway around the world. So yeah, I'm really excited to see what the next 5 to 10 years bring.
Amazing. We have incredible genomics talent in Australia and a lot of great opportunities. So I'm excited as well. Thank you for taking the time to be with us today.
Anna, thank you very much for having me.
All right. And thanks everybody, as always, for listening, and we'll see you next time. Thanks, as always, for tuning into the Genetics Podcast. If you enjoyed today's conversation, the best way you can support the show is by sharing it with a friend or colleague who might find it interesting as well. We'd also really appreciate if you could subscribe, rate, and review us on Apple Podcasts, Spotify, or wherever you listen to podcasts. This helps other people discover the show when they're searching for content on genetics, precision medicine, or biotech. We always want to hear from you as well. If you have feedback or questions or want to be featured on the show, you can email us at podcast@sonogenetics.com. You can find me on LinkedIn, Patrick Short. You can find us as well, Sonogenetics, on LinkedIn, or reach out on Instagram at The Genetics Podcast. And finally, a special thank you to the team behind the show who makes this possible. Joy Ismail produces and manages the show. Jane Reddy-Webster keeps us organized, and James Pierce from Selective Frequencies for his expert audio engineering. I'm Patrick Short, your host. Thanks again for listening, and we'll see you next time on the Genetics Podcast.